Welcome back to our Mountain State Pharmacist podcast. I'm happy to have with us some students and a professor from the Marshall University School of Pharmacy. I have Dr. Thomas Pyle, Monis Ali, and Lexi Atkinson. So welcome. I'm going to turn it over to you because the whole purpose of today's podcast is to talk a little bit about the poster presentation that you gave at APHA, and then we're going to have a little conversation afterwards. So I turn it over to the three of you to talk about what your poster presentation was on at APHA.
Our research group in the poster compiled all current legislation in the U.S. that related to pharmacy benefit managers. And then we reviewed, summarized, and coded each law into our own unique category and codes. Before we started reviewing legislation, we developed a coding system that was based on the many different aspects a law could cover involving PBMs. And after we reviewed them, we assigned them the relevant category. And we just, at the end, we kind of just developed some data of seeing how many laws were in each different category.
So in total, we reviewed about 242 laws currently that are applicable in all throughout the different states. Some of the laws that we noticed that were heavily mentioned all across throughout the 50 states that we saw were fair reimbursement and also fair price transparency law. A lot of states also mentioned that anti-competitive prices were, so we identified and reviewed about 242 codes that were applicable all across the United States, all across different 50 states that we have noticed. Some of the common laws that we noticed were some of the licensure requirements all throughout states for the PBMs, and many of them talked about pharmacy protections as to how PBMs cannot place some certain laws in place that restrict pharmacies from doing their healthcare business, stops pharmacies from doing their regular day-to-day issues. Some of the implications of our project are ensuring the patient access and affordability, protecting pharmacies, need for federal reform, and the opportunities for collaboration and advocacy. In conclusion, we can conclude that PBMs do play a very crucial role for determining the accessibility and affordability and transparency of a prescription drug. However, it is important to regulate the pharmacy benefit manager to ensure patients have access to affordable medications and allow pharmacies to operate and remain viable. Currently, we do have a very fragmented state where the PBMs are operating their business. However, all our project is hinting towards is possibly forming a less fragmented area and more of a universal law that allows PBMs to practice in a more solidified way at all across the state where they have different laws across the state and different laws across the state.
Yeah, so our project was really the only project at APHA that focused on pharmacy benefit managers. If you go and looked at all the posters, I believe there were 300 some posters presented, but we were the only ones talking about pharmacy benefit managers or pharmacy benefit manager reform, which I thought was pretty unique in that, it's such a big issue. It's a deep issue that impacts all aspects of pharmacy, including academia. And so for us to be the only project at APHA, I'm hoping that next year we'll see more, and we'll see more as the years come. APHA generally targets all pharmacists, so it's unlike NCPA and some of these other organizations that are primarily focused just on community pharmacy. So that makes a lot of sense why there wasn't more, but I would like to see more. The leadership at APHA now, they have a lot to say about PBMs and the exploitation of pharmacies and patients that we're seeing. So I would guess that maybe there would be some more posters, some more projects, more discussion at APHA next year.
First off, that's amazing that you guys were the only poster project there that was on PBMs, but it's also not surprising when you look at the history of West Virginia. We were some of the trailblazers in PBM legislation, I think starting as far back as 2016 or maybe even earlier. So it's really not surprising that, again, we're leading the charge. And hopefully, like Dr. Powell said, we will have more discussion about that. And later years at APHA and other conferences to really bring people together. I want to start off with a question that from the moment I saw your poster presentation just stuck in my mind. And this goes to both Lexi and Monis, which is what got you interested in this topic? Because I will tell you that if you're not working in like the thick of it, sometimes it's hard to like really understand it. And it's also really hard to like get interested in it. Like I don't have a whole lot of interest in veterinary medicine because I'm not working in veterinary medicine, you know? So that being said, I guess what I'm asking is what got you interested in this topic, and maybe the next step to that being if you've identified somebody who might be interested in it, how do they get started in research and information regarding PBMs? What started your journey?
Before I started pharmacy school, I was a pharmacy tech for 2 years. And I have personally never heard of PBMs, even though like I was in pharmacy every single day. I have never dealt with them. I've never heard of them. But in school, we started learning about different payment methods, how the whole system works, how the prices are negotiated between the manufacturers and also the pharmacies. That's where we learned about how PBMs operate and how they're operating, and a lot of controversies behind them, all the good parts about them, and why we need them. The reason why I got interested in it is because I had such a hard time wrapping my mind around the practice model as to how the PBMs are set up. Granted, I have no exposure to law before, and it was just a question for me to ask that why are these big companies are operating such a way and how they're allowed to operate in such a way. There are many forms of things that we were introduced, like specific drugs being required to be on formulary and they're not being paid if patient is not paying up from certain pharmacies, white bagging, requiring patients to order their prescriptions through an online service. So just learning about all of that got me really interested in seeing as to what is actually going on and how I can help.
So I've worked in a community pharmacy for about a year now. And I also, at the time, before we started this project, I hadn't been exposed or heard much about, pharmacy benefit managers. But throughout school, they brought in different presenters. And one of the presenters was a local district leader of one of the chain pharmacies. And he came in and just was talking about some of the ways that they were trying to, bring in new revenue to pharmacy. But he discussed like pharmacy benefit managers and some of the laws that do hurt, or some of the things that are done that can really hurt a pharmacist delivering, the best type of care. And once we started this project, I really learned about how much we, like for pharmacists in the community setting, are affected. And the more and more, like me and Monis read up a lot before we were presented at APHA. And it was really interesting to see about how much they can affect and restrict or make the ability to provide care easier.
So when I started into pharmacy school, I was of the mindset that I could not bring politics into my practice because I had patients coming from both sides of the aisle, and it wasn't my place to use politics in any fashion to deliver healthcare, limit healthcare, anything like that. And so as a result, I stayed out of politics for a long time. And I was just like, all I want to do is take care of patients. Like that's my thing. That's why I went to school. That's why many of us went to school, was to take care of patients. Shortly after I got out of school and was in the real world, working day in and day out in my pharmacy, I quickly learned that you can't practice in a silo that is without advocacy for patient care, because unfortunately we have a healthcare system that is very costly. And when there is lots of money, that means there's lots of bad players that can make trouble by limiting access. And, we are in a state that can't afford to waste money. We have a state that needs all the help it can get in some cases. And so I started getting more and more involved in the advocacy of our state legislation. And I quickly realized that I can be an advocate for patient care and still be apolitical when it comes to serving my patients. And in doing that, it opened up a better relationship with my patients because they saw that I was willing to put my own personal political beliefs aside to do what's best for patient care. And from 2014 to present, I think I've attended just about every pharmacy day at the Capitol where we have fought for state legislation that either encourages better patient care, or we have fought against bills that would restrict that patient care or access to that care. So all of that to say that I applaud both of you for getting so involved so early on, because it took me getting out into the real world to see you guys have already figured out that we need to be involved in the advocacy for our profession and for our patients, and that when you advocate for patient care, you are advocating for our profession. And so all of that to say, thank you guys for bringing this poster presentation, the only poster presentation on PBM reform, to APHA, where there were hundreds of poster presentations. You guys set the bar of what the expectation should be. We need to be talking about it. And a lot of colleagues in community pharmacy, quite frankly, have their head in the sand when it comes to what's going on around us. Quite often, you'll hear pharmacists complain about not having the resources to take care of patients or not having the staffing to take care of patients. And they don't understand that part of that reason is because we continue to lose profits that should be directed to us. They're diverted to the PBMs. In some cases, as you both know, they're clawed back from us. And the verbiage clawback in itself describes what they're doing. They're taking it from us when we earned it. So from a community standpoint, this is super important, but I want to kind of turn topics a little bit to Dr. Powell, because as a professor in academia, I'm interested what your interest is in this field, because there's a lot of people in academia that don't necessarily see that there is a relationship between PBM reform and the current state of academia in the United States.
Sure, yeah. What really drove me to dive in and investigate PBMs and legislation regarding PBMs was essentially intellectual curiosity and experience. So prior to academia, I was a pharmacist for 10 years, and I practiced in different practice settings. I was a clinical pharmacist, but I was also a community pharmacist. So I think once you become a community pharmacist, you're always a community pharmacist in a lot of people's eyes. For me, that's what made me want to go to school, was to develop that relationship with patients, be a part of the community, provide pharmacy care to these folks. But what we're seeing in academia across the board, it's not just in West Virginia, it's across the nation, we're seeing lower enrollment in pharmacy schools. And I think it's a multifaceted issue. There are many reasons why that is, right? There are other healthcare provider programs like PA programs, nurse practitioner programs that are sort of pulling some of the students that we would have had in the past. But also, you cannot discuss that without talking about some of the working conditions that you're seeing in community pharmacy settings. And whenever you're looking at these working conditions, it's by and large part driven by lower reimbursements to pharmacies, lower reimbursements to community pharmacies, leading to closures of independent pharmacies, pharmacy deserts. These poor working conditions contribute to pharmacist burnout. And then, it's a feedback loop. You go online, you research a career, you're like, hey, I want to be a pharmacist, and you look it up. And a lot of people speak poorly about being a pharmacist, especially in community pharmacy. I've worked in community pharmacy. It can be a very rewarding profession if you have the staff to provide care. So I think that there's not as many people in academia that really recognize the influence that lower reimbursements and working conditions have on enrollment. So that's what sort of drove me to research this. And another thing was, I want to educate the next generation of pharmacists to be advocates for the profession, push the profession forward, know what's actually happening across the landscape of pharmacy. Monis and Lexi have been great students on this project, very inquisitive. This was a project that took a lot of time. It took a tremendous amount of time. And a lot of the conversations were pretty boring, to be honest. We were arguing over verbiage and wording and coding all of these laws. It took a lot of time, but they were good sports about it. They were very interested. And I would say now they're probably more educated than a lot of pharmacists are on this topic. And I hope that they're able to take this forward into their careers and maybe influence change and advocate for the profession.
So you mentioned as a community pharmacist, you wanted to build that relationship with your patients. And I'm going to share a personal story, and it's probably one that you can go out into just about any community pharmacy and talk to a pharmacist that shares the same story. This past year, lost a significant portion of my patients because of a contract from a PBM that did not get signed. And the only thing worse than not being able to take care of a patient is being able to have taken care of that patient for a decade or more and then have them not be able to come see you anymore. And not only was I not able to take care of them after this, but I would see them out in the community. I'd be out at dinner with my family, and they would, come to the table and say, "Oh, I miss you so much. I hate fill in the blank of the other pharmacy that they chose. And I wish that I could come back to you." And, they'd start crying. They'd get so worked up over it. And it took a toll on my mental health. And it was something that I never expected would be a problem for me until it happened. And so in talking with a number of people about what happened with me, I said, think about the heartache or the pain that you go through when you break up with a significant other that you've been with for a decade. Now think of that on a scale of hundreds of people that you lose overnight or seemingly right away due to a pharmacy benefit manager telling that patient that they can no longer use the pharmacy that they've gone to for over a decade. And honestly, in my area, I'm the only pharmacy in town. So for them, it becomes an access issue, an equity issue, that they're not able to get the same level of care that they were getting from me, from whether it be the actual level of care or just transportation to get there, all the social determinants of health that make up whether a patient can get the health care they need is impacted ultimately by what a PBM says they're contractually obligated to. And in the pharmacy benefit manager toolbox of their arguments, they will say, well, they can go to any pharmacy. It's just that their insurance is only accepted at certain pharmacies, which is all fine. And I take care of patients that would opt to use me instead of their insurance, but they can't do that if they're on insulin. They can't do that if they have inhalers for asthma or COPD. There are just some meds that are priced out of the ability for them to come to me and pay out of pocket. They're obligated. They have to go find where their PBM or their insurance will be honored. So hearing that story, knowing the amount of research that you've put in, like this is a very personal topic for me, and I think a personal topic for a lot of our listeners that are going to be listening to this. I would like it to back up for a second, because there may be some people who have gotten to this point in the podcast and still don't really know that much about PBMs. So if you could maybe give a good explanation or description of what they do and maybe some of the terminology that you might hear around PBM reform, things like spread pricing or DIR fees, vertical integration. So I don't know who wants to take what, and you guys can kind of divide and conquer if you want, but if you could give a little more detail as to the landscape of PBMs, so that maybe we have some listeners who are for the first time going to get a good education start.
Yeah, so PBMs, they're a big part of the healthcare delivery in the United States, right? You can't talk about prescription drug pricing, prescription drug channels without talking about PBMs. They're originally developed in the 50s, 60s, 70s to process drug claims. As we went away from paper claims and we started seeing increasing prevalence of prescription drugs being processed through insurance, PBMs were originally developed by pharmacists, actually, when they were developed to provide formularies, lower drug costs across the board, and they took a fee for doing so. But what we've seen over the last 30 years, and even more so in the last 15, is considerable consolidation among the players in the landscape. So we've seen pharmacy benefit managers acquire insurance companies or vice versa, which would be consider what we call vertical integration of pharmacies and PBMs and insurance companies. So whenever we were speaking about PBMs, we were speaking about some of the most powerful organizations in the United States. These are Fortune 15 companies. These companies are wealthy organizations that you really can't negotiate with, right? You were talking about, your patients losing the contract for providing care for a lot of your patients. There's a false narrative that pharmacies can negotiate with these large organizations. It's take it or leave it contracts for the most part. Pharmacies can't negotiate with 25% of your business, 30% of your business, right? The top 3 PBMs control about 80% of the prescription market. The top 6 PBMs control about 95% of the prescription market. So there's really no negotiation occurring. It is essentially a practice where they present you a contract and you can take it or leave it, or you can not serve your patients who you have a relationship with. Pharmacists, ultimately across the board, if you talk to any pharmacist, they want to provide care to their patients. And a lot of times, especially in these independent pharmacies, they will sign the contracts and continue to take a loss on a lot of their medications because they don't want to disrupt this care. So it is a big issue pharmacies are facing, and they're exploited by the PBMs. And whenever I say PBMs, not all PBMs. There are transparent PBMs who are trying to do things the right way to provide affordable medications to patients. But these large PBMs are really exploiting pharmacies. One way is through spread pricing. Spread pricing occurs when PBM pays a pharmacy a lower reimbursement rate for a drug than what a PBM charges the health plan or employer, and they pocket the difference. So they would pocket the discrepancy, and essentially this is big money. Spread pricing is big money. We're not talking a few dollars. We're talking significant dollars. The difference between the amount the PBM charges the plan and the amount it pays is kept by the PBM as a profit, and that's called the spread. So that is spread pricing in a nutshell. This can harm patients, primarily because it leads to patients paying higher out-of-pocket costs for their prescriptions, as the higher cost is passed on to the patient through higher premiums, deductibles, copays. All of the prices that are set by the drug manufacturer are like the net price or the list price. Those things are essentially propped up on false dollars, because the drug manufacturer creates a price, the PBM negotiates off of that price, and whatever they negotiate off of that price, they're able to say, we negotiated down $200, so we get to keep some of that. But the drug manufacturer doesn't necessarily care about what they list the price for. They care about what they actually get. So the incentive is for the drug manufacturer to raise the cost of the drug to ultimately negotiate that down through the PBM, and the PBM pockets that. And then from there, they may pass that along to the plan sponsor in some degree, and they'll pocket some of that as well. So that's essentially spread pricing in a nutshell, a little bit of rebate.
The purpose of a pharmacy benefit manager, in theory, is to lower costs for the patient, to keep costs low. But if you talk to probably 99.9% of patients in the United States, they will tell you that their costs have only gone up over the last 20 years. And so something is broken in this model for sure. And so when I'm talking, so I do a lot to try to educate our patients about PBMs as well, because I think that there's power in numbers. And if we can get our patients to support us in what we're doing to try to help them, that only can improve our odds at getting PBM reform. So a lot of the times when I explain it to them, I really try to cook it down to the most simplistic terms. And I say, okay, you own a store. We'll say that store is like a clothing store. And in this store, you purchase these t-shirts in at $5 and you sell them at $15. And if I'm a PBM, I come in, I look at the price tag and I say, I'm not paying $15 for that. I'm going to go pay $5 for that. And because I have a contract with them, I'm obligated to sell it to them under the terms of that contract. So they walk out the door with that t-shirt maybe at cost, we'll say, at that $5 cost that I made up. And then a few months later, they come back with that t-shirt. They say, hey, remember I bought this t-shirt for $5? I only wanted to pay $2.50 for it. So give me back $2.50. And I kind of have to do that. And this is part of what I think a lot of people don't understand is it's the only model of retail in the United States that functions this way. You don't see that in grocery stores. You don't see that in clothing stores. Any retail establishment has a cost and then a markup that gives them their profit to get there. And you might have some places where there's some negotiation, like when you go to like buy a car and, you maybe can haggle with them a little bit on the price. But in general, the cost is the cost and the retail is the retail, and there's a markup, and that's how businesses survive. That's how they pay the rent, and they pay their staff, and they pay their benefits to their staff. When you shake that model up to where there's no certainty of how much profit you'll get from any certain item, it makes it hard for us to predict the future. And so you see a lot of lack of innovation because you don't know how much money you can accurately predict is going to be coming in to expand your services or to expand your company. And so that's where I really think a lot of people don't necessarily realize the true harm is through the failure for us to be able to plan and to innovate and to hire more staff. There's always this fear of, well, what's the next contract going to look like? What's the next contract going to look like? And you end up with this stagnation, for lack of better words, that you just have to wait it out and see. And so when I lost 30% of my business, granted, some of those claims were losses. So you're, from a dollars and cents side, you're okay with losing claims that are losses. But on the other end of that claim is a patient that's not getting served or not getting served the same way. And that to me is the real harm that they're doing, because you've got patients that have established relationships with the pharmacists that they have come to trust. And, in West Virginia, we're a population that we need to have that trust. That trust needs to be established in our healthcare providers, because there is some social determinants of health that get in the way from making good health choices. and they need us as the educated experts to be able to trust as a resource to get them to that point of better healthcare. So with that being said, I think you definitely described the PBM climate very well. Go into a little more detail on vertical integration, because that really is a more recent phenomenon that is causing some real problems, that it's not as on the up and up, I guess, as you would like. So talk a little bit about vertical integration.
Yeah, so vertical integration is something, like you said, it's newer in the PBM landscape. So we're seeing not only are these PBMs merging, so that would be what we call horizontal area integration, where PBMs sort of acquire one another or merge. But vertical integration is even more so concerning. We're actually investigating that, or the FTC is investigating some of these vertical integrations that have occurred over the last 10 years or so. But the best way to describe it is the insurance company owns the PBM, owns the pharmacy, and they're able to sort of extract profits throughout and pass profits up and down the channel. So whenever I say the PBM owns the pharmacy and the insurance company owns the PBM, that may or may not be the case, but they're all one entity. If you are able to plug a hole in some of the business practices of the PBM and say, okay, you can't do spread pricing, we're going to delink your reimbursement from the cost of the drug. If we're going to do those things, they're able to sort of, you're playing whack-a-mole at that point. You hear that term a lot whenever you're talking about PBMs. They can pass that profitability up the chain somehow, some way. So the insurance company is integrated with the pharmacy, which is integrated with the PBM, all as one entity. And that's across the board. I mean, the top three, of course, but there's more than that. There's maybe 5 or 6 that are really vertically integrated, and they're able to steer the pharmacy business to their specialty pharmacies or to their mail order pharmacies that really limit patients' access, limits where they're able to attain their drugs. Like in an ideal market, right, you would be able to choose your pharmacy based upon the services they provide. So if you are a community pharmacist and you're like, you know what, I want to really expand MTM practices and I want to really provide good quality care. And if a patient recognizes that and they say, I want to go to that pharmacy, well, it doesn't really matter what the pharmacist wants to do. It's what they're able to do with the staff that they have. So if they don't have the staff, the revenue in order to roll out these new services, like you talked about, I think you hit the nail on the head there. It doesn't matter if you don't have the adequate staffing to do that. And with vertical integration, you are essentially such a large organization that controls so much of the prescription drug channel that these small pharmacies really can't negotiate with you at all.
I think that what concerns me is that we're now seeing it not just in small independent pharmacies. We're seeing it in big chains. We're seeing it in academia. We're seeing the effects ripple out into our profession. And I have been following this for a number of years, but the number of closures of pharmacies that we have seen just over the last 2 years has been just very shocking, that it's having that much of an impact, that it's causing people to have to close their doors. And that only leads to more pharmacy deserts. That only leads to more lack of access to services for Americans. I mean, we're talking about it from the professional standpoint, but at the other end of that counter is a patient who just lost their access to their services, their medications. And you mentioned whack-a-mole. I was just getting ready to say that, you know, on a state level, it really is whack-a-mole, because we are trying to implement legislation that helps the state. And if you do it too much, they can find ways around it by hopping across state lines, and they'll just pull the business out of the state, quite frankly. So you have to try to figure out a way to like work with them, but also put in legislation that really advocates for transparency, fair reimbursement, audit integrity, that these are all things that, you know, we're just asking for enough to take care of patients and keep our businesses going. We're not looking to make millions in PBM reform. We're looking to keep our pharmacies open and keep serving our patients. And so I think that's where, before we got on the call today, I talked with Dr. Powell about a recent trip I took for a fly-in to Washington, D.C. to talk to some legislators. And, that's where it needs to happen. And there are bills that are proposed that, hopefully we'll get some traction with. I know that Senator Manchin actually authored a bill to try to help with PBM reform. And so we're getting there. But I think we need more people involved in that space. There's strength in numbers. And, you guys are starting the conversation here on the podcast at APHA. The more people that understand what it is that's going on, the more we can grow that advocacy reach to impact change. And so I thank you guys so much for not just your poster project, but being willing to talk about it on a state and national level. And I want to give you time to maybe final thoughts on where do we go from here? What is the next step in PBM reform based on the research that the three of you have done?
We saw, of some of the things that, we've talked about, all about keys and, the audit process. Interestingly, the second most common law that we saw was limiting the scope that a PBM could do during an auditing process. But there was only a couple laws. So I say we only had 17 laws that established laws preventing those patient steering them to the mail order pharmacy, things like that. And so I think that just showing that, although those numbers could be considered small and considered to the auditing one, but I think it gets a good conversation going that it's a good start for a universal, just to help deliver the best patient care. And like you said, patient steering can really harm how a patient gets care. And then we also had two states, I believe it was Minnesota and Louisiana, that were the only ones that actually had a law preventing DUR fees, which I think is a good step in the right direction. But our project was more of just getting all the information together so that you're able to view and see how fragmented the landscape is currently, and to help maybe steer the discussion of federal reform.
I will just add to it that if you think about it, the first week of all of the pharmacy school, we take an oath where we take this oath along the lines of embracing and advocating for changes for the patient care, and laws and regulations, just like PBMs and which we're facing right now, they go right along our oath. This is not our a volunteer opportunity for us to take a part in. I think it's our job and our oath that we have taken, and we are advocating for our patients by working through this whole mess of all the PBMs that we're seeing. I do think that even though the process is relatively slow as we would like, but we are moving in very positive direction in the future.
From my perspective, we think about how do we get PBM reform? And I think that it takes efforts like the West Virginia Pharmacists Association does. I think you guys do fantastic work. All the state associations, I think, are looking at this in a certain degree. But I think a really important thing to keep in mind whenever you're talking to any stakeholder in this conversation is exploitation of pharmacy is exploitation of patients. If you exploit a pharmacy and they're closed their doors or they're not able to provide the highest level of care possible, you're exploiting a patient. So having a for-profit entity determine pharmacy reimbursements with no fiduciary duty exploits pharmacies, but then it exploits patients as well, indirectly and also directly. So keeping that frame of conversation that, hey, exploitation of pharmacy is exploitation of patients. I think it's going to take a united leadership among all pharmacy organizations that continue to beat the drum of PBM reform. We're seeing that with APHA. The APHA president is very pro PBM reform. He's very vocal. He said a lot of good things. I was on a call with the president-elect. He is saying the same thing. So I imagine that the continued, he'll pass the torch and continue that leadership. We had NCPA on the Hill last week, and so it's not just the top 2 organizations, top 3. It's pretty much every organization in pharmacy is starting this conversation. Federal lawmakers are now aware of what PBMs do, which is really, really cool. You know, we've had at least 2 bills pass committees in past either the House or Senate, which is big at a federal level. You know, at state level, things pass pretty regularly. At a federal level, not so much. So, and I think we have to look at state level successes as well and sort of model that. We've seen great success in Medicaid managed care carve-outs throughout the country. I think there are at least 5 or 6 states that have implemented Medicaid managed care carve-out, and they've saved significant millions of dollars for their state, which is promising. So carving out prescription drugs from managed care and essentially going to a fee-for-service model instead of a capitation-based model for pharmacy makes a lot of sense, and it saves money. And then in terms of this year and what could happen, it's really hard to say what will happen in the lame duck session. You know, we have, it's an election year. We have the same 2 presidential candidates. There's a lot of things on a political landscape that we have to consider. And passing legislation is not a science. It's much more of a soft skill. It's more of an art. It's timing. You know, a lot of these PBM related bills, almost all of them have bipartisan support. So, which is unheard of today, right? I mean, we're so divided politically across the country. To have something with bipartisan support seems like it would pass with flying colors, and we'd hang our hat and say, well, man, we did a great job here. But, you know, like I said, it's not necessarily support. It's more of an art. It's not a science. So during the lame duck session, we'll see what happens. We weren't able to get anything past it most recently, but we will see, and hopefully we see some continued conversations, hopefully sooner than later, for these pharmacies who are really struggling, these small pharmacies and also chain pharmacies who are really struggling.
Yeah, I'm pretty sure that we can't get both sides to agree on what color the sky is, but get them to agree that PBM reform is necessary. And so it's just a matter of us continuing to inch closer to that finish line. And the efforts that you guys have put together, I think, is a step in the right direction for all of us. I do want to point out a couple things for our listeners. So if you go to our website, which is wvpharmacy.org/PBM-reform, there is a whole page on what we have done in the state of West Virginia with reference to West Virginia code about different PBM statutes that we've put in place. But there's also a button to file a complaint with the Office of Insurance Commissioner. So we have fair reimbursement laws that for commercial plans and Medicaid that we are, and just recently PEIA in this last legislative session that we are promised a given rate for. And if pharmacies are finding that they're not getting reimbursed that rate, they need to file a complaint with the Office of Insurance Commissioner so that they can research it and try to make sure that the PBMs are playing by the rules in our state, that we have dictated that is how we want pharmacy to practice in West Virginia. And if they're not meeting us at that point, we need to hold them accountable. And that starts with filing that complaint. The other thing I will mention is that if you want to know more about PBM reform, go in the liner notes for this episode, and we'll have some resources there for you to kind of dig in a little bit more. I'm going to put the link to your poster presentation there so that they can actually see the poster itself. And you can go back in our podcast history. I want to say it's episode 3 or 4. Early on, we were talking about PBM reform, and we had some pretty big names on that podcast that are advocating, have been advocating for PBM reform for some time. It's a topic that if you want to learn more, there's an infinite amount of knowledge out there to find. You just have to know where to look and do the work for it. But there are tons of nonprofits. There are tons of organizations that are working to try to get PBM reform across the finish line. And in every single one of those is some absolute great literature. So we'll try to link some of that in the liner notes for the episode so that you can find it very easily. But again, I want to thank Monis and Lexi and Dr. Powell for their time on the podcast today, and probably the countless hours of boring research that you put in, that as boring as it may be, man, is it important. So thank you so much for that work. And I look forward to seeing continued work in this space from the three of you and from other people across the state and country. So thank you.
Thank you for having us.
Thank you, Matt.
Thank you.